Every day we prescribe standard doses of anticoagulants, but for some patients that standard dose is a lifesaver, and for others it's a direct ticket to the emergency room. Why? Because your liver doesn't read the textbook, it reads your DNA. Today we are decoding the big three of cardiovascular pharmacogenetics. We are going from the high evidence world of warfarin through the critical activation of Clopidogrel to the controversial and debated evidence surrounding DOACs. If you want to move beyond trial and error and into precision medicine, you are in the right place. Welcome to the NextGen Pharmacist. Warfarin is the original Goldilocks drug of cardiology. Give a patient too little and they risk a life-threatening stroke. Give them just a milligram too much and they are at risk of major bleeding. For decades, we have played a guessing game called trial and error with the INR. Warfarin therapy is notoriously challenging due to its narrow therapeutic index, where even minor fluctuation in plasma concentration can shift a patient from a safe state to a life-threatening hemorrhage or thromboembolic failure. Achieving a stable time in therapeutic range, TTR, is a complex balancing act influenced by a multitude of factors. Clinical variables like age, body surface area, and baseline liver function significantly impact clearance. Dietary interactions, fluctuating vitamin K intake from green leafy vegetables directly antagonizes warfarin's mechanism, necessitating strict dietary consistency. Drug-drug interactions like amiodarone or fluconazole and various antibiotics can inhibit CYP2C9 rapidly, spiking INR levels. Finally, variations in VQRC1 and CYP2C9 account for 50% of dose variability. To understand the genetics, we have to look at two sides of the coin: pharmacodynamics, what the drug does to the body, and pharmacokinetics, what the body does to the drug. First, the target, VKORC1. Warfarin works by inhibiting the enzyme vitamin K epoxide reductase. The gene encoding this VKORC1, a common polymorphism -1639GA, determines how much of this enzyme a patient naturally produces. If they have the AA genotype, they produce less enzyme and are highly sensitive to warfarin. They need a much lower dose. Second, we have the engine, CYP2C9. This is the primary metabolic pathway for the more potent S-warfarin isomer. Variants like CYP2C9 star 2 and star 3 significantly reduce enzyme activity. And for CYP2C9 star 1 is the normal wild type. But the carriers of star 3 can have a 90% reduction in clearance. If you dose a star 3 homozygote with a standard 5 mg, you aren't just overdosing them, you are potentially sending them to the ER. For a long time, we only talked about CYP2C9 and VQRC1. But the latest data and the CPIC guidelines have expanded the scope. CYP4F2. Think of this as the vitamin K sink. It clears vitamin K from the liver. If a patient has the CYP4F2 star 3 variant, they have higher levels of vitamin K. These patients are actually warfarin resistant and often requires higher doses than average. Second, ancestry matters. RS12777-823. This is a critical update for clinicians. In patients of African ancestry, the standard CYP2C9 star 2 and star 3 are less common, but this variant is a major predictor of dose. Ignoring this leads to a poor outcome in diverse population. So, how we actually use this? We don't just guess, we use validated clinical genetic algorithms. So, according to most updated CPIC guidelines, we should use websites like warfarindosing.org, which allow you to input the patient's age, weight, race, and genotype to get a precise milligram per day recommendations. According to the most recent CPIC guidelines, if you have the genotype before the first dose, you can reach a stable INR faster and significantly increase the time in therapeutic range. So warfarin remains the gold standard for mechanical heart valves and certain antiphospholipid syndromes. In these high-stakes patients, pharmacogenomics guided dosing isn't just a luxury, it's a safety requirement. In cardiology, we often say time is muscle, but what if the drug we use to save the muscle never actually turns on? Clopidogrel is one of the most prescribed antiplatelet agents in the world, but for millions of the patients, it's essentially a placebo. Why? Because clopidogrel is a prodrug. It's biologically inactive until your liver transforms it. If your genetics don't allow the transformation, your stent is at risk. Clopidogrel is a thienopyridine antiplatelet agent, primarily indicated for the prevention of atherothrombotic events. It's widely used for the secondary prevention of myocardial infarction (MI) and stroke in patients with established peripheral arterial disease, recent MI, or recent stroke. Furthermore, it's severe as a mainstay of therapy in acute coronary syndrome, including unstable angina, STEMI, and non-STEMI, and is critical for preventing stent thrombosis in patients undergoing PCI. This diagram illustrates how thienopyridine prodrugs, common antiplatelet medications like clopidogrel or Prasugrel, work to prevent blood clots. First, the drug is taken orally and absorbed into the bloodstream. It travels to the liver as a prodrug. It is inactive initially and requires hepatic enzymes to convert it into an active metabolite. This active form then re-enters systematic circulation. Normally, when platelets need to activate and clump together, a process called aggregation, they use chemical signal named ATP. This ATP binds to specific P2Y12 receptors on the platelet surface, causing them to activate and aggregate. The thienopyridine active metabolite stops this process by specifically targeting that P2Y12 receptor. It binds to the receptor irreversibly. ATP can no longer bind, preventing the signal for platelet activation. Because this permanent bond is formed, that specific platelet remains inhibited for its entire lifespan, about 10 days, resulting in overall decreased platelet aggregation. Most of the clopidogrel a patient swallows is inactivated by the esters and never reaches the platelets. Only a small 15% fraction goes through a two-step hepatic oxidation. The MVP of this process, CYP2C19. This gene is highly polymorphic. We categorized patients into 5 main phenotypes: ultra-rapids, star 17, and rapid, star 1, star 17. These patients are superactivators. Normal, star 1, the expected response. And intermediate, star 1 plus LOF, they carry one loss of function allele like star 2 or star 3. And finally, we have poor metabolizers who carry 2 loss of function alleles. If you are an intermediate or poor metabolizer, your body cannot produce enough active metabolite to inhibit the P2Y12 receptor. The result? High on-treatment platelet reactivity and a significantly higher risk of major adverse cardiovascular events. The CPIC 2022 update is very clear, especially for ACS and PCI patients. Let's look at the avoid list. For poor and intermediate metabolizers, the recommendation is a strong avoid for clopidogrel. Instead, we switch to Prasugrel or ticagrelor. These alternatives don't rely on CYP2C19 for activation, making them genotype independent. What about the superactivators, star 17? While they have higher levels of active metabolite, the data, including the 20-25 meta-analysis, shows they don't necessarily have a higher bleeding risk. For them, standard 75 mg dosing remains the strong recommendation. A common question I get: can we just double the Clopidogrel dose? The Elevate Timey 56 trial showed that even tripling the dose in poor metabolizers didn't achieve the same platelet inhibition as a standard dose in a normal metabolizer. So the recommendation: switch, don't just increase. We now have the clinical evidence to back this up. Trials like Popular Genetics showed that a genotype-guided strategy was non-inferior to universal ticagrelor Prasugrel, but significantly reduced bleeding costs. In 2024, the American Heart Association released a scientific statement finally supporting pharmacogenomics screening for antiplatelet selection. As a pharmacist, your role isn't just to check for prescription, it's to check if the patient's engine can actually run the fuel they have been given. The CPIC 2022 update officially expanded recommendations to include patients with minor ischemic stroke or high-risk transient ischemic attack. For patients identified as intermediate or poor metabolizers, CPIC recommends using an alternative antiplatelet, typically ticagrelor, to ensure adequate platelet inhibition and reduce the secondary stroke burden. While Prasugrel is a potent alternative to Clopidogrel in the cardiac setting, it carries a black box warning and is strictly contraindicated in any patient with a history of TIA or stroke. But still, ticagrelor as alternative to Clopidogrel in neurovascular indications has a moderate classification, unlike the strong classification for ACS and PCI. Now, we have seen how genetics can completely change the game for Warfarin and Clopidogrel. But what about the new kids on the block? Before we dive into why DOAC evidence is still so poor, I want to invite you to subscribe to the NextGen Pharmacist. Anticoagulation is just the beginning. In our upcoming Masterclass series, we will be decoding the genetics of statins, antidepressants, and oncology agents. Don't miss out on the tools that will define the future of your pharmacy practice. Hit that subscribe button and let's look at the DOAC dilemma. When DOACs, direct oral anticoagulants, hit the market, they were hailed as the Warfarin killers. No more INRs, no more dietary restrictions, and supposedly no more dosing headaches. But as pharmacists, we know that drug response is never truly universal. We see some patients bleed on standard doses and others fail therapy. So, where's the pharmacogenetics for DOACs? Why aren't we testing genes for apixaban or rivaroxaban like we do for warfarin? Today, we are looking at the evidence or the lack thereof. While DOACs don't have a narrow therapeutic index like warfarin, they do rely on specific transporters and enzymes. First, the gatekeeper ABCB1. This gene encodes P-glycoprotein. All DOACs are substrates for this efflux pump. If a patient has a variant that makes PGB overactive, they absorb less drug. Second, we have the activator, CES1. This is specific to dabigatran. It's a prodrug activated by carboxylsterase 1. Variants here can lead to lower active drug levels. Then we have the cleaner, CYP3A4, used significantly by rivaroxaban and apixaban for metabolism. On paper, the genetics look significant. So, why aren't we genotype guiding this drug in the clinic? Here's the next-gen truth. The clinical evidence for DOAC pharmacogenetics is currently poor. Unlike warfarin or Clopidogrel, there are no CPIC level A or B guidelines for DOACs. Why? First, we have the clinical dominance. Factors like age, weight, and renal function have a far greater impact on DOAC blood levels than any single genetic SNP discovered so far. And the second reason is safety buffer. DOACs have a wider therapeutic window. Small genetic variations in concentration don't usually push a patient into a danger zone the way they do with warfarin. So, current meta-analysis suggests that while genetic markers like ABCB1 explain some variation, they don't yet predict bleeding or stroke risk accurately enough to change a prescription. For now, the gold standard for DOAC dosing remains physiology over philology. Focus on renal function and drug-drug interactions with PGB inhibitors. Will we have DOACs pharmacogenetics in the future? Perhaps. But as of 2026, we follow the data, and the data says, watch the kidneys, not just the code. The future of pharmacy isn't just about dispensing, it's about interpreting. By using a patient's genetic blueprint, we transform anticoagulant therapy from a dangerous into a precision tool. If you are a clinician, start looking into preemptive testing. If you are a student, master these pathways. They are the foundation of precision medicine. Thanks for watching this deep dive on the NextGen Pharmacist.